everyone. Today we are going to talk about skin infestation. A 45-year-old lady presents to the dermatologic clinic with a rash that has been present intermittently over past 3 years. On examination, there's symmetrical rash over the cheeks, nose, and chin with multiple papules and pustules. Which one of the following is the most appropriate therapy for this lady? So let's see, is a middle-aged woman who had a rash for quite some time, which is symmetrical over her cheeks, nose, and chin with multiple papules and pustules. So rash over face with papules and pustules usually has to be acne or acne rosacea. So which one of the following is the most appropriate therapy for this lady? Is it prednisolone, isotretinoin, oxytetracycline, hydroxychloroquine, or flucloxacin? Of course, the choice will be oxytetracycline. The description is of acne rosacea, particularly in view of the distribution, duration, and absence of any other features, and given her age, the most possible diagnosis is acne rosacea. And especially when the nose is involved in acne, in centrofacial acne, you can have similar picture, but the erythema, telangiectasia, papulopustular lesions, sometimes you can have a bigger nose, there can be ocular involvement, all can be seen in rosacea. So here you can see in acne vulgaris, there are different stages of comedones, papules, pustules, and nodules. And whereas in acne rosacea, you see mostly papules and pustular lesion. There can be telangiectasia, and erythema is very marked. And rhinophyma is the consequence of non-treated and sometimes, it leads to granulomatous infiltration of the nose, giving rise to this huge nose. And patients with ocular rosacea may complain of gritty, burning, foreign body sensation of their eyes. So do ask your patients whether they have any eye involvement. Now, the general recommendation by British Association of Dermatologists for rosacea, limit exposure to known aggravating factor like alcohol, sun exposure, hot drinks, spicy food. They can all increase the flushing of the face and lead to aggravation of the rosacea symptom. Topical therapies like ivermectin, metronidazole, azelaic acid are the first line of topical treatment. Consider brominodine. It reduces the erythema, or oxymetazoline in people with rosacea where the persisting feature is facial erythema. Among systemic therapy, tetracyclines are not used any longer. Usually we prefer doxycycline, azithromycin, clarithromycin, then erythromycin, limecycline. These are specially used. Try and avoid minocycline in these people because unless there's no other treatment, because minocycline these days are very important medicine used for many other infections, systemic infections. Consider intermittent courses of low-dose isotretinoin in people with persistent and severe rosacea. Actually, isotretinoin works very well in rosacea. And in order to reduce the erythema, we can use IPL, that is intense pulse light, pulse dye laser, or NDR laser in order to reduce the redness of the face and the telangiectasia. Which one of the following assertions regarding diabetic foot ulceration is correct? Skin infection is the most common initiating event in ulceration. Radiography can readily distinguish between Charcot's joint and osteomyelitis. Plantar ulceration is most common due to atherosclerosis. Callus formation at pressure areas is an important predictor of ulceration. Autonomic neuropathy results in increased resting blood flow. So, which one is more likely to be true? That is the question they're asking. The answer will be D. Callus formation at pressure areas is an important predictor of potential ulceration. Plantar ulceration is usually a consequence of neuropathy, and minor skin trauma is probably the most common initiating event. Blood flow is often decreased with autonomic neuropathy, and hence sympathectomy may be performed to improve the skin blood flow. It is radiographically very difficult to distinguish between Charcot's joint and osteomyelitis. A little bit more about this diabetic foot. So, diabetic foot is usually characterized by classic triad of neuropathy, ischemia, and infection. And patients with peripheral neuropathy, peripheral vascular disease, foot deformity, and presence of callus, these are the predictors for development of foot ulceration. Diabetic foot ulcers are common and estimated to affect 15% of all diabetic individuals during their lifetime. It is now appreciated that 15 to 20% of the patients with such foot ulceration go on to need an amputation. So, if timely measures are not taken, the foot is difficult to save. Neuropathy in diabetic patients is manifested by because of the motor damage to the innervations of the intrinsic foot muscles that leads to imbalance between the flexion and extension of the affected foot. And this produces an anatomic foot deformity that create abnormal bony prominences and pressure points, which gradually cause the skin to break down and ulcerate. Autonomic neuropathy leads to diminished sweating. The overlying skin becomes very dry and increasingly susceptible to fissures and subsequent development of infection. Sensory loss as a part of peripheral neuropathy exacerbates the development of ulceration. So, how to treat ischemia and diabetes? More distal vessels below the trifurcation, such as peroneal, anterior, and posterior tubules, are commonly involved. Surprisingly, foot vessels such as dorsalis pedis are often spared. Infection in diabetic foot is a limb-threatening condition because the consequences of deep infection in diabetic foot are more disastrous. The foot has several compartments and which have intercommunicating areas, and infection can spread from one compartment to other. And lack of pain actually allows the patient to continue ambulation, further facilitating the spread. Osteomyelitis generally results from a contagious spread of deep soft tissue infection to the cortex of the bone marrow. A majority of deep, long-standing foot infections are associated with osteomyelitis. Neuropathy leads to fissures, bulla, neuropathic Oshapurja, neuropathic edema, digital necrosis. Ischemia leads to pain at rest, ulceration on the foot margin, digital necrosis, and gangrene. Differentiating between these two entities is essential because of their complications are different and they require different therapeutic strategies. The management of diabetic foot ulcers includes several facets of care. Offloading, that wearing proper shoes, debridement are considered vital to the healing process for diabetic foot wounds. Infection control, it's because it's limb-threatening and superficial infections are usually caused by gram-positive cocci. Deep infections are usually polymicrobial. All patients with deep infection should be hospitalized and started on broad-spectrum antibiotics. Dressing, sometimes newer dressings like film dressing, foam dressing, non-adherent dressing, hydrogels, hydrocolloids, alginates, they all can be helpful. Number of adjunctive wound care treatment like recombinant platelet-derived plasma has been used for ulcer healing. Revascularization, surgical bypass is also sometimes done, and prevention is the key to save a diabetic foot. So if timely care is taken, we can probably prevent a lot of complication in diabetic patient. The next patient is a 68-year-old obese lady with a history of type 2 diabetes who attends the outpatient department for a review. She has an extensive erythematous skin rash affecting the underside of both breast and skin folds over her lower abdomen. In spite of using topical moisturizer, she says her skin is breaking down, it's itchy and bleeding. Her blood pressure is 150/90, pulse normal, she's apyrexial, body mass is, BMI is raised, the rash is moist and yellowish adherent plaques and papules around the edges. Routine blood reveals elevated plasma glucose and serum CRP was raised, but the rest of the laboratory values are unremarkable. Our most recent HbA1c is 7.8%. So this is an overweight, uncontrolled diabetic lady who presents with erythematous rash over her skin folds. Which one of the following is the most useful intervention for a presenting skin pathology? Intensified glycemic control, topical terbinafine, topical clotrimazole, topical hydrocortisone, oral fluconazole. So we can see this lady is already having a fungal infection which is quite extensive. Glycemic control is needed in sugar patient, but for her immediate relief, these topical preparations are not going to help, so oral fluconazole will be the right answer. The presentation here is consistent with candida-related intertrigo as a result of this patient's diabetes, which is uncontrolled, and obesity, which leads to skin fold maceration, and there's increased chance of fungal infection. The debate is between topical and oral therapy. Given this patient has extensive infection and history of diabetes, oral intervention is preferred over topical application. Oral fluconazole can be given over a period of 2 to 4 weeks. Intensified glycemic control will be useful in reducing the risk in future, but it's highly unlikely to eradicate the current problem. And as such, antifungal intervention is preferred. Both topical clotrimazole, terbinafine options in patients with more limited infection. Hydrocortisone may be added where there is marked inflammation, but cannot be used as a monotherapy. 20 Next patient, a 28-year-old gentleman, presents to the dermatology clinic with concerns regarding displeasing appearance of his toenails. They have whitish discoloration extending up to nail bed in a number of toes of both feet. Dermatophyte infection is confirmed. He has been cutting his nails carefully, applying topical amlorphine without any effect. Which one of the following is the most appropriate management of his condition? Oral fluconazole, oral terbinafine, topical fluconazole, topical terbinafine, or topical benzoic acid. So this is a gentleman with a dermatophyte infection of his nail, and they have discoloration. So the most appropriate answer will be B, oral terbinafine. Terbinafine has been shown to be more effective for nail infection. One should offer treatment with oral antifungal in adults with confirmed nail infection, as self-care measures or topical treatment are not always successful. Terbinafine is recommended as first line of treatment because it's effective against dermatophyte and candida species, whereas azoles do not have much efficacy against dermatophytes. So terbinafine will be the preferred choice. So the medications that can be used for topical nail infection is amlorphine, cyclopyroxolamine, tioconazole. For systemic infection, the main systemic drugs for onychomycosis are terbinafine, and sometimes itraconazole can also be given in form of pulse therapy. And you can see the discoloration of the nails, and this whitish discoloration. There can be distal onycholysis. There can be subungual hyperkeratosis. That means underneath the nail there will be some accumulation of the tissue. That is called subungual hyperkeratosis. Next patient, 24-year-old sportsman, returns from tournament in Greece after a month with a tan and numerous scaly hypopigmented lesion on his neck and upper trunk. Which one of the following is the most anticipated diagnosis? Pityriasis rosea, chronic plaque psoriasis, sebum, discoid eczema, pityriasis versicolor. So sportsman returns from tournament with a tan with scaly hypopigmented lesion. So we have to think of the conditions which is aggravated by sweating. So these are this pityriasis, psoriasis, or discoid eczema has not much relation with sweating. Whereas seborrheic dermatitis, yes, that can aggravate, but it won't causes this hypopigmented lesions, which gets aggravated with sun exposure. The only option will be pityriasis rosea, with the areas that are hypopigmented that doesn't get tan. So pityriasis is caused by superficial fungal infection called Pityriasporum ovale, usually presents a slightly scaly hypopigmented lesion. Growth is encouraged by an increase in temperature, suntan oils, and most commonly seen after a sun holiday, because the rest of the area gets tan and the affected area remains hypopigmented. Chronic plaque psoriasis, discoid eczema, and seborrheic dermatitis have distinct appearance and distribution, and pityriasis rosea usually starts with a hairal patch, which follows by further small scaly lesions, and which has an inverted fir tree appearance. It mostly affects the trunk. Then we have an 18-year-old lady who presents to the clinic with extensive integrated hypopigmented, slightly scaly lesion on her back and chest. The rash has been present for 3 years and gradually become more extensive. She is otherwise fit and well. The lesions are not symptomatic, but she is concerned about the appearance. Which one of the following is the most appropriate treatment of a condition? So again, going back to the history, extensive, hypopigmented, slightly scaly lesion on her back and chest. And it's present for quite some time, which is not bothering her other than the cosmetic appearance. So the tentative diagnosis again will be pityriasis versicolor. So which one will be the most appropriate treatment? Oral terbinafine, nystatin, acyclovir cream, oral itraconazole or ketoconazole cream. So the answer is ketoconazole cream. Lady presents with asymptomatic eruption on her trunk. Lesions are scaly, hypopigmented, not associated with systemic disease. And this is characteristic of pityriasis versicolor, which is caused by pityriasis oval and pityriasis orbicule. The yeast is lipophilic and encouraged by an increase in environmental temperature. Thus, many patients notice that the condition begins after summer vacation. It is a disorder of the healthy, but the immunocompromised are at risk as well. The condition is asymptomatic and fungus affects the melanocytes, hence you get the hyperpigmentation. Treatment includes topical imidazole creams, selenium sulfide shampoo, and if not responding to topical treatment, you can give oral itraconazole 200 milligram daily for 7 days. And this lady, because she was quite asymptomatic for so long, so topical treatment should be the first treatment of choice. Next patient, a 52-year-old lady and a 23-year-old daughter presented to the clinic with multiple itchy red lesions over the trunk and groins. The daughter had initially developed the rash after working out in the nearby fitness center, following which the mother noticed a similar rash bothering her. Which one of the following is the most plausible diagnosis? So mother and daughter both got similar kind of multiple itchy red lesions on trunk and groins. So allergic contact dermatitis, fixed duct eruption, sarcoidosis, tinea, psoriasis. So it has to be some infection because both of them got it. So the most likely diagnosis, of course, will be tinea corporis. Dermatophytosis is common in young adults. It usually presents as annular scaly ducts with central clearing. The lesions are typically itchy and they increase in number with, if not treated, any area of the body can be affected, but usually the covered area where there's more sweating, those are the areas mostly affected. The condition is contagious and typically spread in immediate contacts, such as in family members. Allergic contact dermatitis usually will present with some sort of dermatitis, itchy papulovesicular eruptions. Fixed duct eruptions, usually erythematous or hyperpigmented macule, which can reactivate with history of drug exposure, which can be itchy, and they usually reappear in the same space. That is why it's called fixed duct eruption when they are exposed to a similar group of drugs. Psoriasis is a papulosquamous lesion, so they have a distinctive feature. Sarcoidosis may present in various forms of plaque lesion, papular lesions, or various morphology can be present, but mother-daughter having at the same time definitely is not diagnostic of sarcoidosis. A 17-year-old girl had treated with permethrin cream for scabies, and with the treatment being replaced after 7 days as recommended. On follow-up 1 month later, she found to have continuing inversion. Which one of the following is the most likely reason for this? Facial skin was not treated. The treatment was not repeated for a third time. Household members were not treated. The organism is resistant to permethrin, non-disposal of undergarment. So when we ask to apply this anti-scabitic treatment, we ask them to apply from neck to feet, overnight application, which has to be repeated. And usually treatment of the family members is also advised because it's a very contagious disease. So the most likely reason would be all the household members were not treated properly. Scabies is an intensely pruritic, highly contagious infestation of the skin acquired through close personal contact. It is a type 4 hypersensitive reaction to the mites and the eggs or excreta and occurs after 30 days after infestation and is responsible for intense pruritus, which is the hallmark of the disease. Treatment is topical, often with permethrin. Application should be repeated 7 days after initial treatment to kill the mites, which will hatch the eggs. And if done properly, treatment failures are usually uncommon. Recurrence of eruption usually means reinfection has occurred, and this is often from close household contacts. All household members and close personal contacts should therefore be treated whether or not they are symptomatic, and the patient should be re-examined 2 weeks after the treatment to evaluate the effectiveness. Next, we have a 17-year-old girl with scaly patches on her scalp and is brought to the clinic by her parents for review. Examination revealed well-circumscribed circular areas of hair loss 1 to 5 centimeter in diameter, scaling and raised margin. There is no scarring. Which one of the following is the most likely cause of this presentation? Discoid lupus, lichen planus, systemic lupus, tinea capitis, morphia. So 17-year-old girl with scaly patch over her scalp with the circular areas of hair loss, and it shows scaling and raised margin, and there's no scarring. So when there's no scarring, so discoid lupus is excluded. Lichen planus, when it occurs in scalp, again it can cause follicular prominences and scarring. SLE usually cause diffuse hair loss. Tinea capitis is the most likely diagnosis. Morphia will again lead to scarring alopecia, and there will be sclerotic changes on the skin. The girl has non-scarring alopecia due to invasion of the hairs by dermatophytes, most commonly trichophyte and tonsills. The most common cause of non-scarring alopecia include telogen effluvium, androgenetic alopecia, alopecia areata, which is an autoimmune disease, tinea capitis, and traumatic alopecia. Less commonly, non-scarring alopecia is associated with lupus and secondary syphilis. Or as a matter, for any chronic disease, they can have this hair loss. Scarring alopecia is more frequently the result of primary cutinous disorders such as lichen planus, folliculitis decalvans, cutaneous lupus, or linear scleroderma or morphia. So usually there are various kinds of scalp tinea. This is Trichophytum rubrum, where we also call it black dot. You can see that because of the breakage of the hair, it looks like black dots. Then Microscopium canis, this is a zoonotic fungus, Trichophytum violacum, and Carian is another severe response. This is again due to zoonotic fungus. There's a boggy swelling on the scalp, usually seen in children, but adults can also have it. And treatment best treated with brysofulvin, and sometimes steroids is also needed in order to treat this Carian. A 7-year-old girl with crops of asymptomatic rash over her trunk for 3 months was admitted to pediatric ward. Examination reveals skin color to pearly white and hemispherical to umbilicated papular lesion. Each one is approximately 3 millimeter diameter, approximately 18 of these lesions present. Which one of the following is the most anticipated diagnosis? So, crops of asymptomatic rash for 3 months. Skin color to pearly white, hemispherical to umbilicated papular lesion. And it is all 3 millimeter. They are very small papules and they're numerous. So, which one is the following diagnosis? Folliculitis. Folliculitis is inflammation of the follicles that will be painful, and these are asymptomatic, so rule out. Herpes simplex won't be present for 3 months, and it does not increase in number. Warts usually have a warty appearance. They don't have an umbilicated papular appearance. Cutaneous cryptococcus, again a 7-year-old girl with no other symptoms, with so many lesions. Cutaneous cryptococcus will be very distant diagnosis. Molluscum contagiosum is the only common infection that happens in children, which presents as pearly white hemispherical papule with umbilicated appearance, and because they're contagious, they keep on spreading from one lesion to another. So the diagnosis of molluscum is obvious, and child presents with pearly white hemispherical lesions. HIV positive patients may have cryptococcosis. Cryptococcus neoformans affects 5 to 10% of AIDS patients in United Kingdom and USA, and 30 to 40% in Africa. 20% patients have disseminated disease, can have skin involvement. In HIV/AIDS, cryptococcal skin involvement should be suspected when papulonodular necrotizing skin lesions are seen with central umbilication. And like molluscum contagiosum are encountered in such patients along with pulmonary and neurological disease, but they are much more inflammatory. They have much more inflammatory appearance than molluscum. Hence, cutaneous cryptococcosis must be kept as a differential diagnosis for umbilicated lesion. Folliculitis, a painful papulopustular follicular lesion. Herpes simplex infection presents with recurrent group vesicular eruption on an erythematous breast at the mucocutaneous junction. And warts, as I mentioned, will have verrucous plaques, and papules are more commonly seen over the extremities. So here you can see molluscum contagiosum. This is this dot, this is umbilicated appearance, as if it has been punctured inside. But of course, if you press, nothing comes out. We have to deroof the lesion in order to remove them. Warts have warty surface, folliculitis, inflammation of the follicles with erythema, and herpes simplex. You all know that cold sores, they have group blisters, which are persist for 3 to 5 days and then they disappear. They won't persist for 3 months. Cryptococcosis, as I just mentioned, is caused by encapsulated is Cryptococcus neoformans and Cryptococcus grati. Primary site of infection is lung with strong tropism for the central nervous system, and this is frequently manifest with signs of extrapulmonary dissemination involving skin in 10 to 15% of the cases. Dissemination usually occurs in immunocompromised hosts, AIDS, lymphoreticular malignancy, sarcoidosis, SLE, and those patients who are on long-term immune suppression or patients of organ transplant. CNS involvement treated with intravenous amphotericin B combined with flucytosine followed by oral fluconazole. In immune suppressed patients, the initial treatment are similar, however, long-term maintenance treatment are required with fluconazole. And in immune-competent patient, non-disseminated, non-CNS Cryptococcus infection can be treated with oral fluconazole for 3 to 6 months or with itraconazole for 6 to 12 months. Next, we have a 15-year-old girl diagnosed as scabies. Which one of the following statements regarding scabies is correct? Cause itchiness in the skin even where there is no obvious lesion to notice, caused by Staph aureus, typically affects face, can spread by droplet infection, and is best treated by salicylate emulsion. Of course, the answer is A. That means it causes itchiness of the skin even there is no obvious lesion present, because it could be a hypersensitive reaction to insect parts as well. Scabies is an infestation of the skin with microscopic mites, Sarcoptes scabiei. Infection is common, found in worldwide, and affects peoples of all races and social classes. Scabies spreads rapidly under crowded conditions, and frequent skin-to-skin contact happens, especially in hospitals, institutions, or child care facilities, nursing homes. It can spread by direct prolonged skin-to-skin contact or with person already infected with scabies. Contact must be prolonged. Infestation usually spread in sexual partners and household members. It can be shared. It can occur by sharing clothing, towels, bedding as well. It's characterized by papular like irritations, burrows, or rash on the skin, especially on the 𝑽𝑰𝑫 space, skin folds, wrist, elbow, knee, lower abdomen, private parts, breast. Number of treatments are available for scabies, including permethrin ointment, benzyl benzoate, oral ivermectin for resistant cases. Antihistamines and calamine lotions may be used to alleviate itching. And usually for Norwegian scabies or Scabies can be extensive in patients who are neglected, who doesn't take bath for days together. They can have this disseminated scabies infection. Ivermectin works wonder for them. A 48-year-old lady presented to the clinic 4 weeks after she returns from backpacking holiday in Sweden with a shallow, painless ulcer of the nose. Which one of the following is the most plausible diagnosis? So after a backpack holiday, she developed a shallow ulcer, which is painless. Is it trypanosomiasis, Fuchsibacterium ulcerans, squamous cell carcinoma, trichomoniasis, or leishmaniasis? So since it is a 4-week duration, unlikely to be squamous cell carcinoma, because usually they will be present for some time before it comes to notice. The answer will be E, or leishmaniasis. Given the history, the likely diagnosis is cutaneous leishmaniasis. Lesion, pain, and pruritus may be present in cutaneous leishmaniasis, but not typical. Diagnosis is by histological section and with staining for 𝒕𝒉𝒆𝒄𝒌. Leishmania brasiliensis is the likely pathogen which is spread by sandfly bites in the endemic areas. Fuchsibacterium causes topical ulcer, which is intensely painful, and they have a shallow ulcer. So it's newly described obligatory anaerobic gram-negative non-spore forming rod that has been isolated from tropical ulcers is they are slender rod-shaped bacilli with pointed ends. Strains of Fuchsibacterium cause several human disease, including periodontal disease, Lehmann's syndrome, and topical skin ulcers. Trichomoniasis usually causes itching, burning, redness, and soreness of genitals, discomfort when peeing, and clear white, yellowish, greenish vaginal discharge is usually noted, and there is a fishy smell. And staining can reveal this like organism. Leishmaniasis is a parasitic disease that is found in parts of tropics, subtropics, and southern Europe, classified as a neglected tropical disease. Leishmaniasis is caused by infection spread by the sandflies. Old world leishmaniasis occurs in Africa, Asia, Middle East, Mediterranean, India, causes cutaneous and visceral disease. And New World leishmaniasis species found in Central and South America produces cutaneous, mucocutaneous, and visceral disease. It's very important that you know this bit of leishmaniasis because you can have a lot of multiple choice questions. Visceral leishmaniasis are also called kala jar, is fatal if left untreated over 95% of the cases, characterized by bouts of fever, weight loss, enlargement of the spleen and liver, and anemia. Most commonly occur in Brazil, East Africa, and India. An estimated 50 to 90,000 cases of visceral leishmaniasis occur worldwide, but usually not reported that well. Cutaneous leishmaniasis is most common form that cause skin lesion, mainly ulcers on exposed part of the body. This can leave lifelong scars and cause serious disability or stigma. 95% of cutaneous leishmaniasis occur in America, Mediterranean basin, and Middle East and Central Asia. Mucocutaneous leishmaniasis spread leads to partial or total destruction of the mucous membranes of the nose, mouth, and throat. And 90% of this mucocutaneous leishmaniasis occur in Bolivia, Brazil, Ethiopia, and Peru. So cutaneous leishmaniasis includes foreign features. Localized leishmaniasis presents as crusted papules or ulcers on exposed skin, and lesion may be associated with sporotrichotic spread. That means it can spread along the lymphatic channel. So you can have multiple lesion as well. Diffuse cutaneous leishmaniasis, multiple widespread, non-tender, non-ulcerating cutaneous papules, nodules, analogous to lepromatous leprosy lesions. Leishmania recidivans presents recurrent lesions on the site of apparently healed disease years after original infection. And post-Kala-jar dermal leishmaniasis develops months or years after recovery from visual leishmaniasis, and cutaneous lesion ranging from hypopigmented macules to erythematous papules, nodules, and plaques, and they are numerous and they persist for decades. Treatment pharmacologic therapies, pentavalent antimony sodium stibogluconate, used for cutaneous leishmaniasis. Liposomal amphotericin B, it's effective against pentavalent antibody-resistant mucocutaneous disease and visceral leishmaniasis. Oral miltefosone, approved by FDA. Intramuscular pentamidine. Orally administered antifungals, allopurinol, dapsones have also been tried. And topical paromomycin, effective against cutaneous leishmaniasis caused by Leishmania major and Leishmania mexica. But the key drug is sodium stibogluconate for leishmaniasis. Trypanosomiasis is generally used to refer African human trypanosomiasis, also known as African sleeping sickness. African sleeping sickness is an infectious disease caused by parasite Trypanosoma brucei gambiense or Trypanosoma brucei rhodense and transmitted by tsetse fly. So it is usually in first 2 weeks, 2 to 3 weeks. In stage 1, it spreads to lymphatics. Then in stage 2, it spreads to central nervous system. And in stage 2, they can develop severe neurological symptoms, sleep disturbances, and in last stage, they develop convulsion, coma, and other co-infections. Drugs that are used for treatment in first stage is pentamidine and suramine. Drugs used in second stage, melarsoprol, eflornithine, or eflornithine plus nifurtimox, according to WHO guidelines. Trypanosomiasis skin manifestations, a painful chancre that appears 5 to 15 days after the bite, resolves spontaneously after several weeks. Intermittent fever, which is refractory to antimalarials, general malaise, myalgia, arthralgia. Then they develop generalized lymphadenopathy, facial edema. There can be transient arterial erythematous macular lesion. Trypanids, they are ill-defined, centrally pale, evanescent, annular, blotchy, erythematous macule that are seen in trunk. They are known as trypanids. The standard serological assay for diagnosing West African trypanosomiasis is card agglutination test for trypanosomia or CAT, and a wet smear of unstained blood or 𝒉𝒄𝒎𝒔 stain with right and Leishman stain can show this trypanosoma organism. 48-year-old lady attends a clinic with pityriasis versicolor. Which one of the following is the most appropriate first-line management? Phototherapy and ultraviolet, methotrexate, oral terbinafine, topical selenium sulfide, psoralen, and UVA. So 48-year-old with pityriasis versicolor. So most appropriate treatment will be topical selenium sulfide, because for pityriasis versicolor, we don't use phototherapy and ultraviolet light or PUVA therapy. They're mostly for vitiligo, psoriasis, or atopic dermatitis. Methotrexate again for psoriasis. Oral terbinafine for severe fungal infection. Yes, they can be used, but topical selenium sulfide should be the drug of the choice. So pityriasis is caused by Panacea farfar. Treatment should be topical selenium sulfide. Oral itraconazole is also effective if the topical doesn't help. Thank you.